Well, good morning, everyone. And thanks to Cliff for inviting me here, although I must say, when I got a phone call on my mobile phone whilst walking the dog earlier this year in the fields in England, I thought Cliff said, would you like to come and give a talk in Australia? When the paperwork arrived, I realised it was Austria, not Australia still. It's a great honour to be sharing the podium with Joel Cooper, who I remember well as a senior registrar some 15 years ago when the volume reduction surgery was reinvented, really, and it's due to his enthusiasm that we took on this operation in the United Kingdom. And I'm just going to just present our take on volume reduction surgery, which highlights in some ways the difference between the American mentality and the more conservative British mentality. We know the thoracic changes with emphysema that Joel's highlighted and the importance of hyperinflation and the effect on chest wall mechanics. This is the basic reason why these patients have symptoms. Their lungs are too big, their thoraces are overinflated. And with surgery, as Joel's highlighted, you can improve the mechanics of the rib cage and therefore improve the symptoms of breathlessness. However, it's always been sold as a bilateral operation. You have to cut out the badness in both sides. But we hypothesise that the thorax is not two rigid compartments, more that it is a movable feast, and the mediastinum can move quite freely from one side to the other, as we've seen in tension pneumothorax and lung collapse. And so we hypothesise that removing lung tissue just from one side could have significant effects on hyperinflation and on the contours of the diaphragm on both sides. And this may be a more conservative and less risky way of achieving what we set out to do in the first place. The question of how you perform the operation, of course, has probably never been fully resolved, but it seems sensible that if you are operating to improve the function of the patient's rib cage and their sensation of breathlessness, you should do as little damage as possible in doing the operation. And that's why we prefer a video-assisted thoracoscopic approach rather than a median stenotomy. There's evidence either way that shows that there is similar improvement by whichever method you use, possibly higher morbidity after median stenotomy, but there may be a learning curve experience in that, and possibly a faster recovery, and importantly, a cheaper overall cost by video-assisted surgery. The question about whether you should operate on one lung or two has never again been really addressed in a randomised fashion. Bob McKenna's early results suggested that there was no difference in operative risk, but a higher late mortality after unilateral LVRS. Unfortunately, of course, these two groups were not comparable, and the patients who only had unilateral disease had a more severe degree of emphysema, and they were not suitable for bilateral surgery. It was one important fact, however, that there was a greater short-term improvement from operating on both lungs, as you would expect. But this then resulted in a faster decline in FEV1. So you got a bigger initial benefit, but it didn't last for as long. And we certainly found that there were less complications and less cost in our National Health Service from doing one lung rather than two. And we therefore went away from doing open bilateral operations to video-assisted single-sided operations, even in patients with bilateral target areas. And you can see there now that almost exclusively we do unilateral staged VATS operations for this disease in patients who otherwise have bilateral target areas. There have been other European experiences of this approach. Bill Walker's group in Edinburgh reported in 2003 a comparison of unilateral versus two-stage operations, which showed no further significant improvement after the second operation, but it did prolong the benefit by over a year. And similarly, the group from Rome, who in some ways were forced into operating in a two-staged scenario due to air leaks or whatever, noted a significant improvement after 48 months, i.e. a long-term improvement, only in those groups of patients who had their operations staged, implying that you may get a longer overall benefit from spreading out the operation. What if the operation wasn't planned by the surgeon? I think we all accept now that volume reduction surgery is primarily intended to improve the health status of the patient. Patients don't come into the clinic and say, "Doctor, my FEV1 is lower today than it was yesterday." They say they're more breathless, they can't do their housework, they're unable to do things they were doing 3 or 4 years ago. So who's the best arbiter of health status? The doctor or the patient? And therefore, who is the best at deciding when the second operation should be performed? And I'll put it to you that it's the patients themselves in this condition. And this is the strategy that we have adopted in our practice over the last 10 years. We've also slightly altered our operative technique. We use video-assisted surgery. We try to keep the incisions in one intercostal space to reduce the problems of post-operative neuralgia. We use one of the incisions for a chest drain. We perform the standard upper lobe resection, removing 30 to 40% of the upper lobe, using the azygos vein as a landmark. But we also do operations in lower lobe predominant emphysema. And we don't exclude them on the basis of their anatomy, providing they fulfill the other selection criteria. We also slightly altered how much we take and where we take it from. Joel's initial reports suggested taking the apex of the upper lobe, but we've tried now to do more akin to the operation described by Brantigan and remove the peripheral tissue around the whole circumference of the upper lobe in order to leave less of an apical space, to remove a complete donut rather than just a horseshoe. To get over the problem of obtaining these patients for operations, with the privilege of having a state healthcare system, we run multidisciplinary teams where patients referred to a specialist pulmonologist for emphysema treatment, whether it be medical treatment or rehabilitation, are all discussed with the surgeons and radiologists in a joint meeting. This means of those patients, we get to see patients who are unsuitable, but we can help make that decision. And we tend to operate on just under half of those that we turn down. Some patients we have referred on for endobronchial therapy within clinical trials in the UK. This is a way round, I think, of not seeing the patients who may be suitable, so get in league with the pulmonary physicians and try and discuss the cases at source, similar to the way we approach lung cancer now. In our experience, we have operated on 166 patients who can be analysed in long-term follow-up. 50 patients only had a unilateral target, but 116 had bilateral targets identified on CT and perfusion scan. 26 of those in the start of the cohort underwent one-stage bilateral VAT surgery, and 90 patients underwent subsequently the unilateral staged procedure. But interestingly, of those 90 patients, only 16 have elected themselves to go on to the second side. That's only 14% of the patients, and it's taken them an average of 4 years to reach that decision, until their health status determined that they requested the second-sided operation. And these patients were kept under regular follow-up by the pulmonary physicians and by us. Of the 74 who have not yet proceeded to the second stage, 30 have died from other comorbidity or from chest infections. 11 have become inoperable using the strict selection criteria, usually because of poor diffusion capacity and increasing hypercapnia. But 33 are still undecided, but are still suitable for the operation. There's no difference in their preoperative lung function. They all fulfill the standard criteria. But if we look at their perioperative change in FEV1, as you can see and has been highlighted before, there's a greater initial improvement by doing both lungs at the same time, but a greater subsequent decline. And so if we look at our comparative groups, admittedly small groups of patients, but significant changes are seen. If we look at the one-stage bilateral patients, their FEV1 benefits last for up to about a year from baseline. But if you look at those patients who are currently going through this protocol of asking for the second operation, they get a second benefit at 4 years, where their FEV1 again reaches significant improvement. Although after one-stage operation there is a significant reduction in volume, it doesn't last, and the volume starts to increase again as the emphysema progresses. However, in these patients with a second-stage operation, we maintain the volume reduction for up to 6 years, both in changes in TLC and in residual volume. We're very privileged to have a captive population, so we have very complete health status follow-up up to 6 years. And we use the SF-36 rather than a specific respiratory disease questionnaire. There's no significant benefit in physical functioning after a year with this policy, but interestingly, in the other significant groups of social functioning, there is an improvement in their social functioning, their health status, for up to 6 years by a staged procedure. And similarly, in the domain covering energy and vitality. And in Euroqual, a more blunt tool for assessing quality of life, the two-stage operation has a longer benefit, a more prolonged maintenance of health status improvement. And so while one-stage stage surgery with 2 lungs gives FEV1 improvement for only 6 months and volume reduction for 2 years, and a health status improvement for only 12 months, a staged approach gives a second wind benefit in both lung function measurements, volume reduction, and importantly, in health status. And importantly, staging the operation by up to 3 or 4 years does not increase the overall risk of the patients in these groups. You can see there is similar mortality and longer-term survival, both in terms of mean and median survivals, and there is no significant overall difference. So we're not putting the patients at overall risk of mortality by delaying their second operation. So in conclusion, from our experience over the last 10 years of a policy of a more conservative approach, our early results suggest that a more prolonged strategy, determined by the patient themselves rather than by the surgeon, seems to lead to a sustained benefit without compromising survival. But the patients need to be warned, and they are kept under medical follow-up, not to defer their second operation for too long, as they run the risk that their physiology may have deteriorated and preclude them from further operation. But we do feel justified, and we have not gone back on our decision to not adopt the standard United States NET trial conclusion of one-stage bilateral surgery. And could it be that the British tortoise will in the end outlast the American hare? Thank you.
Thank you, David. There are clearly different ways to skin the cat. And our last speaker for session